Assalamu alaikum, dear students. This is the third lecture in clinical genetics, in which we are going to discuss genetic counseling and prenatal diagnosis. What we mean by genetic counseling? Genetic counseling is a communication process between the genetic counselor and the parents or family of the child affected by the genetic disorder. And during this communication, many issues are discussed. For example, the contribution of genetics to health, the mode of inheritance, the recurrence risk, complication of the disease, the life expectancy, and so on. And then to advise the family and help them to adapt to the problem and to support them psychologically. What are the indications for genetic counseling? First, advanced parental age, especially maternal age above 35 years, paternal age above 50 years, and if there is previous history in the family or in the child with congenital abnormality, dysmorphology, mental retardation, or history of metabolic disorders, chromosomal abnormalities, or single gene disorders, and in case of consanguinity, that is the marriage between relatives, if the mother exposed to certain teratogens, then to detect or screen heterozygotes, that the carrier states, if there is repeated pregnancy loss in the mother, and abnormal neonatal genetic testing. To provide accurate information to families, we require first taking a careful and detailed family history and constructing a pedigree that lists the relative with their sex, age, and state of health. Then to document prenatal, natal, and postnatal histories, followed by careful physical examination, then to review the latest available laboratory and genetic information concerning the disorder, establishing the diagnosis by diagnostic tests in order to put the management plan and follow-up. So we will take Down syndrome as example for genetic counseling. In the beginning of the interview or the communication between the parents and the doctor or the genetic counselor, we have to congratulate the parents for having a new baby and then to assure them that we are here to support them. The first question the family might ask, why has this happened? And why my baby and not others? Then we will tell that it is a genetic disorder and then discuss with them according to their level of education. The other question parents may ask, will it happen again? That's what we call recurrence risk. In 95% of cases of Down syndrome are due to nondisjunction, and it is related to the maternal age. For mothers younger than 25 years, the risk is 1 for each 600 to 800 live births. For those above 35, the risk is 1 over 350. And for mothers with advanced age above 40 years, the risk is 1 in each 100. And if a couple has a child with Down syndrome, the risk is higher for the next pregnancy and is going to be 1%. In 4% of cases with Down syndrome due to translocation, and this is not related to maternal age, the frequency is 1 over 500. The recurrence risk is as follows. If the translocation is between the chromosomes 21 and 21, the recurrence risk is 100, so all children will be affected with Down syndrome because there is no normal chromosome number 21. But if the translocation between 21 and chromosome 14, 13, or 15, the risk of recurrence is 12% if the mother is carrier for the abnormal chromosome and 3% if the father is the carrier for that abnormal chromosome. A pregnant mother who had a previous child with Down syndrome may come and ask you, what can be done to know if her new baby will be normal or she might have another baby with Down syndrome? In this case, we will send her for prenatal diagnosis, and in a prenatal diagnosis, we have the maternal screening and diagnostic testing. For maternal screening, if she is in the first trimester, we will send her for ultrasound for nuchal translucency or blood test for PAP, that is pregnancy-associated plasma protein A, which is decreased in this case, or beta human chorionic gonadotropin, which is increased in this case. In the second trimester, we will send her for alpha-fetoprotein, which is increased in this case, and the human chorionic gonadotropin, estriol, which is decreased in this case. In the diagnostic testing, we have the chorionic villus sampling at 9 to 11 weeks and amniocentesis at 14 to 18 weeks. One usual question the family will ask is whether their baby is going to be a mentally retarded one. The average IQ in Down syndrome is 50 to 60, but it varies. Then we have to tell the family that a child with Down syndrome is at a higher risk for the development of hypothyroidism, diabetes mellitus, celiac disease, leukemia, congenital heart disease, hearing loss, epilepsy. What health care can we extend to the child? First, echocardiogram at time of diagnosis, hearing and vision test, thyroid function test, cervical spine X-ray, health supervision for children with Down syndrome. Thank you for your listening.